Hi, I'm Enrica Orsini, scientific lead at EHA Education, and I'm here today to speak about classification and risk assessment of myelodysplastic syndromes with Maria Teressa Voso. Maria Teressa, do you want to introduce yourself?
Yes, good afternoon. I am Maria Teressa Voso. I am professor of hematology at Tor Vergata University in Rome. And I am, from a scientific point of view, very interested in MDS, myelodysplastic syndromes, and acute myeloid leukemias.
Well, so to start, can you summarize what is the current diagnostic approach to MDS today? It is just based on blood and marrow examination plus cytogenetics, so there is a role also for molecular genetics, and in which patients?
Yes, as you mentioned, the diagnosis of MDS is based on morphology, proportion of bone marrow blasts, peripheral blood counts, in particular hemoglobin levels, neutrophils and platelet counts. But increasingly, there has been a role for molecular genetic analysis. Karyotype is usually performed in all patients, but also somatic mutations have been shown to play a significant role for the diagnosis, but also for the prognosis of the patient, so to identify targeted treatments or to identify patients who are at higher risk of progression and of death, and to stratify them for specific treatments.
So they are currently included in the diagnostic workup, or they are not, or that sometimes yes, sometimes not?
Okay, ideally,
exactly.
They should be included for all patients. One must say that there are situations when the karyotype is complex, or when there are specific prognostically unfavorable karyotypes, where probably NGS and the mutation profiling doesn't really change the therapeutic and the therapeutic approach mostly, but there are some other areas, like in patients with a normal karyotype, for instance, younger patients, where the mutation profiling can help to define a treatment strategy, including also allogeneic stem cell transplantation. So, I would say that, we try to perform NGS in all younger patients, and in elderly patients if the NGS is going to change the treatment approach.
Well, speaking about the treatment approach, MDS are treated on the basis of low risk and high risk. How this low risk and high risk are currently assessed? So what are the prognostic indexes that are used to classify?
Yes, there is a clinical genetic prognostic system, which is the IPSSR, which has been developed in 2013, and this includes blood counts, cytogenetics, and blast proportion in the bone marrow. This is the score on which many drugs have been approved, and so it is the basis for treatment indications for many drugs. Recently, in 2022 and also in 2021, mutation profiling has been incorporated into prognostic scoring systems, and in particular we had in 2021 the Euromed score, and in 2022 the IPSSM. This is a score which incorporates the mutation status for 34 genes, and in addition to IPSSR, cytogenetic stratification, and also takes into account hemoglobin levels, platelet counts, and bone marrow blast proportion. The advantage of this molecular score over the IPSSR is that IPSSR identifies 5 prognostic groups in MDS from very low to very high risk MDS, while the IPSS-M identifies 6 prognostic groups, better defining the intermediate prognostic group, and also better defining the favorable prognostic groups, because the addition of some mutation can really change the prognosis of the patients and be an alert for time to progression, a shorter time to progression, which is an important indication for physicians treating MDS patients.
Can you make an example of some of this?
Yes.
The most important, let's say, something.
Yeah, I mean, there are several examples that we can make. For example, patients with 5q minus MDS with TP53 mutations are at high risk of progression, so they should be monitored, especially if they are younger, and if transplantation is feasible in case of disease progression. Patients with a normal karyotype may have a FLT3 mutation, ITD, which is included in the IPSS-M. And of course, FLT3 ITD is a mutation which is associated with proliferation and so progression, similar to NPM1 mutations, which according to the new AML classification define AML. So this is a major change, and so we can identify using molecular profiling those cases of MDS, old MDS, NPM1 mutated, which now belong to the AML category. And so this is a big change for the patient, for the treatment choice, and so I think this is a very relevant information. And then we have the whole field of TP53 mutations. Of course, these are associated with complex karyotype in 80% of cases, but we can identify multiple TP53 mutations using NGS, and we know that B-allelic TP53 mutations are prognostically unfavorable and define and are disease defining. We know that there is a TP53 mutated AML MDS and AML MDS according to ICC, and so I mean this is very important to define B-allelic TP53 mutations. We would actually need additional methods such as FISH and also array CGH, but there are clinical hints towards the definition of B-allelic TP53, such as the association of the presence of TP53 mutations at over 20% variallelic frequency, the association with complex karyotype, and the association of a TP53 mutation with a 17p deletion, which are all evidences for multiple TP53 defects.
This seems to make the diagnostic workup much more complicated.
Yes,
and
it
does.
Is
it feasible?
Well, I think that it is nowadays feasible in most university centers, and I would say most big centers. We are trying to make efforts in order to give the possibility to do extensive diagnostics also to smaller centers, and this is done through lab networks such as the GIMEMA LabNet in Italy, for instance, and I know there are similar experiences in other countries. On the other hand, I think that we should you know, as I said before, we should try to do to perform diagnosis as precise as possible in most patients, but you know, just always keeping in mind what are the therapeutic possibilities for these patients. MDS with ring sideroblasts have now an approach, a therapeutic approach, which is a relatively new drug, luspatercept, but we can identify those patients also using Pearl staining. And so, I mean, the indication for the treatment can be based both on Pearl staining and on the presence of SF3B1 mutations. On the other hand, we know that, for example, the two new classifications are making life not that easy.
To everyone.
To everyone. They're very similar for MDS, but you know, if we think of MDS with ring sideroblasts, ICC defines these only according to the presence of the SF3B1 mutations, while the WHO also accepts the morphologic definition using Pearl staining. There is a big issue for the AML-MDS category in the ICC, which is not recognized by WHO, and I think this is the major difference between these two classifications, and that will require some work, validation, especially from a therapeutic point of view, to show that these patients with an MDS can be treated like IML with intensive treatment with similar schedule. I think this is very open.
Coming back to the risk scores, what is the situation in clinical practice? I mean, the IPSS-M is going to be the standard, will replace, do you think, the old one? Are patients that at low risk with the IPSS-R score, but that can have some kind of high risk mutation, actually being treated as high risk, or this is not validated yet?
Yeah, well, it is not validated yet. Most protocols are still based on the IPSS-R,
yeah.
And so patients are included in protocols also using new drugs according to the IPSS-R. The IPSS-M is useful, but needs validation. I think, you know, if you have a young patient with normal karyotype and a TP53 mutations, but no blasts, peripheral blood counts, which are not so severely reduced. So we put this patient under special surveillance. So these are patients that need to be very closely monitored. I'm not sure whether, I don't think that we can now really change the treatment for these patients. Yeah. If we find a B-allelic TP53 mutation, usually these patients have a clinical picture which is a lot more aggressive, more severe. So there is
I
think we need to validate this scoring system. I can mention one paper validating the IPSS-M versus IPSS-R in the context of allogenic stem cell transplantation, especially in hypoplastic MDS, and in that context there was not a significant advantage for IPSS-M versus IPSS-R. So, I think it's a very helpful resource. We need to take into account the mutation status for many situations, but we should keep both scoring system in the daily practice until we have more data.
Thank you very much. That was very clear. Thank you.
Okay, thank you.